If you've ever stared at an arterial blood gas printout, you know the feeling. It looks like a chaotic, unreadable string of numbers. The three-step method provides a fixed set of rules to solve arterial blood gas interpretations, regardless of their complexity. To use this system, you must first memorize the normal reference ranges: a pH between 7.35 and 7.45, a partial pressure of carbon dioxide, or PCO2, between 35 and 45 millimeters of mercury, and bicarbonate, or HCO3, between 21 and 28 milliequivalents per liter. Following this process maps those figures directly to a precise physiological picture of your patient's survival state. Step 1 is establishing the primary disturbance. Look at the pH first to determine if the patient is in a state of acidemia, a pH below 7.35, or alkalemia, a pH above 7.45. You find the primary driver by looking for the value that matches the direction of the pH. In metabolic acidosis, both pH and bicarbonate drop. In metabolic alkalosis, both rise. For respiratory acidosis, a low pH matches an elevated CO2. For respiratory alkalosis, a high pH matches a low CO2. Let's apply this to a specific patient case. Their labs show a pH of 7.25, a bicarbonate of 14, and a PCO2 of 30. The pH of 7.25 is low, indicating acidosis. The bicarbonate of 14 is also low. Because they move in the same direction, the bicarbonate is the matching value. While the PCO2 is also low at 30, a low PCO2 would typically cause an alkalosis, not an acidosis. This confirms the primary diagnosis is metabolic acidosis. Isolating this primary driver is the mandatory foundation. Without it, you cannot move on to a deeper analysis. Step 2. If you identify a metabolic acidosis, you must immediately calculate the serum anion gap. The anion gap is a measurement of unmeasured anions in the blood. These are organic acids that have dissociated and are contributing to the acidemia, occupying the space between your measured electrolytes. Use the formula sodium concentration minus the combined total of chloride and bicarbonate. The standard normal range for this result is 12, plus or minus 2. Note that newer hospital autoanalyzers measure chloride differently, which can lower the normal reference range to between 3 and 9 milliequivalents per liter. You must always check your specific lab standards. Calculating the gap is critical because it splits metabolic acidosis into two distinct clinical pathways, each with entirely different causes and treatments. Step 3 is evaluating compensation. We are checking to see if the patient's body is responding appropriately to the shift in pH. In metabolic acidosis, the lungs should respond by hyperventilating to blow off excess carbon dioxide. Winter's formula tells us if that drop in CO2 is sufficient. The expected PCO2 equals 1.5 times the bicarbonate, plus 8, plus or minus 2. Let's return to our patient. They have a bicarbonate of 14 and a measured PCO2 of 30. 1.5 times 14 is 21. Adding 8 gives us 29. With the plus or minus 2 margin, the expected PCO2 range for this patient is 27 to 31. Since the patient's actual measured PCO2 is 30, they fall perfectly within the expected window. This compensation is adequate. If the CO2 was higher or lower than that range, it would prove a second hidden respiratory disorder was present. When the primary problem is respiratory, the lungs cannot compensate for themselves. The task falls to the kidneys, which must adjust bicarbonate levels. Because the renal system moves slowly, compensation is categorized into acute and chronic phases. For a primary respiratory acidosis, we use the 1 to 4 rule. For every 10-point increase in CO2, the bicarbonate should rise by 1 millimole per liter in an acute case, or 4 millimoles in a chronic case. In respiratory alkalosis, the bicarbonate drops by 2 in the acute phase and 4 in the chronic phase for every 10-point decrease in CO2. Identifying these ratios lets you determine exactly how long the patient has been in respiratory failure. There is one specific scenario that frequently misleads clinicians. Imagine a patient with COPD who is also experiencing severe vomiting. Their pH is 7.40, PCO2 is 60, and bicarbonate is 36. The pH of 7.40 is perfectly normal. Always remember that compensatory mechanisms do not fully normalize the pH on their own. A normal pH paired with abnormal secondary values is a major warning sign. Here, the respiratory acidosis from the COPD and the metabolic alkalosis from the vomiting are pulling the pH in opposite directions. These two primary processes have essentially fought to a draw at 7.40, masking a dangerous mixed acid-base disorder. That is the framework. Find the primary disturbance, check the anion gap, and evaluate the compensation. Following these steps allows you to assess respiratory or renal failure with clinical confidence. Screenshot this cheat sheet and use it to interpret the numbers on your next shift.